Welcome, everyone, to this healthcare forum sponsored by the League of Women Voters of Brown County and the League of Women Voters of Bloomington, Monroe County in Indiana. I see we have people from Ohio and California and Colorado, so we're in Indiana. I'm Karen Greenstone, I'm your host, and Kathy Roundtree in Brown County. I'm in Bloomington, and Kathy Roundtree in outside of Nashville is our chat moderator. You're welcome to turn your camera on, and please keep your voice muted. After the presentations, the program will be open for questions at the end. To ask a question, please send your name to the one question moderator. You will be called upon in order received for one question, and if time does permit, participants may ask a second question. Please be succinct in order to make time for everyone. Community Access Television, CATS, is recording this session, including the questions and answers, and future requests can be made of CATS to see this presentation again. So the seeds for this forum were planted last spring when the National Ad Hoc League Group Healthcare Reform for US, or HCR for US, was asking for help to support a concurrence at the National Convention in July of 2022 to update the League of Women Voters healthcare position. That seed has come to fruition tonight with help from many League friends who have supported us in planning this event, and from our distinguished panel, who are all League members. Barbara Pearson is a member of the League of Women. I'm going to introduce them now. Barbara Pearson is a member of the League of Women Voters, Amherst, Massachusetts, and a member of the LWV networking group, Healthcare Reform for US, HCR for US. Barbara is retired from the University of Massachusetts Amherst Department of Linguistics. And Barbara will talk about the League Healthcare Update and advocacy within the League and working in partnership with other groups.
She said to turn on our camera, but I didn't. Yeah.
Dr. Rob Stone is a member of the League of Women Voters, Bloomington, Monroe County. He is a member and board advisor for Physicians for a National Health Program and a partner organization working with many leagues throughout the country. He is the state coordinator for Medicare for All Indiana, and Dr. Stone practices palliative medicine in Bloomington. He will refresh our understanding of single-payer Medicare for All and the ongoing healthcare crisis. Joey Ballard, League of Women Voters Indianapolis, is a third-year medical student at the Indiana University School of Medicine and is a member of Students for a National Health Program, SNAP, associated with PNHP. Joy will talk about his advocacy work and student activism within Students for a National Health Program. So let's start with you, Barbara.
Okay, well, thank you. Should I share my screen? I will try.
Yes, go ahead.
Here, this one is what I want. And then I will do this. So I am thrilled. Oops, I better not talk until I get what I need. I'm thrilled to be here with you tonight. This is so exciting. And Rob and Joey are going to do all the heavy lifting. My job is to tell you about the concurrence that Karen introduced to you and try and figure out how that, how the concurrence, can you hear me? Yeah. And how that concurrence is going to be helping our state and local leagues advocacy. So, and she already told you I'm a member of this. Our network, which we'd love to have you join, is gets together once a month, but we have a lot of activities and we motivate each other and network and share best practices. And it's been going since 2005 and hopefully on to the future. So I wanted to have two parts to this. One is about the concurrence, why, what, and how a little bit. And then part two, so what? What does the update give us? And I I was concerned about whether it changes when we can identify ourselves as league members, and also what kind of groups we seek out. I'm not sure that's anyway. And then in part 3, where to learn more. I think we'll all together do that. So why do an update? What has changed? Why use a concurrence? What does New York State have to do with it? What does the concurrence do? As I said, what does it leave as was? And what does it clarify? And what does it add? Basically, what has changed since 1993, as I say, more on this from Joe, Rob, and Joey, but just basically that we're in worse shape than we were in 1993 when the healthcare position was first put forward. Fewer Americans with affordable healthcare, increasingly expensive for the families, for taxpayers, and our public health is worse. Okay, our outcomes are worse, and our disparities are getting worse too. So, are you all familiar, I hope, with impact on issues? Can somebody nod for me? Impact on issues is the policy, is the book that the League puts out every other year that incorporates all of its public policy statement positions.
Barbara,
yes,
I'm so sorry. None of us can see your slides. They continue to be loading. So
are you kidding?
I'm so
Okay.
sorry. I know that you have some slides, but all it
I
says
do.
is loading. So
It's
I
still
wanted to
loading.
interrupt
My
you
goodness.
just to let you know, and then I'll mute.
Okay, well, okay. They're not too exciting yet, but we'll see.
Maybe try again.
So do you see, so you just see a screen that says loading, loading, loading?
Yes.
Correct.
It did that before, but before it showed, right? Well, let me go on. Let me see.
There you go.
You see my screen now,
Yes, they're up.
but it's not the real, I mean, it's, you see the screen with all the garbage around it, right? Not the big slides.
Yeah, it's not in presentation mode, but we can at least see it now.
You can see what it is. I tell you what, I'll go back to trying to get the others. While is it say loading again?
No?
But now they're up?
Yes.
Oh, okay. So, well, I've been through these. And mostly I'm just reading them, to tell you the truth. So basically I got into where the position before the concurrence, I mean, we've had a great position all the time. It's for universal, comprehensive, affordable, equitable healthcare for all the residents of the United States. And the position has like these 6 or 7 positions, six or seven parts. And then there's a little history that goes with it, which is not exactly the position. But basically, when you do a concurrence, putting us back to summer of 2021, New York had just updated their position. They had looked at their position and at the national position and said, well, you know, we're working on a lot of stuff in healthcare in our state, and we really don't feel like there are some very specific things that we could put into the position that would make it more useful for us. So they did a big study, a big 2-year study, went through the process. And so there we were, we had the New York study, we had the older position, which had been once updated by a concurrence from Colorado to add behavioral health. And we got encouraged we spoke with leadership of LWVUS, and they encouraged us to try and figure out what we would like to put in and how we could strengthen the position. So mostly it stays the same, because when you do it, you can't change anything, but you can add. And so we clarified some elements, we added some elements. So one of the things that these are four things that we typically clarified: separate insurance, make single payer support explicit in the position. It was implicit before. We'll see that in a minute. Allow states to enact universal health care until Congress does. And then they made some additions to the guidelines for cost control. So let me just show you a little bit. You see this now? Okay, you see it? This is one of the ones I wanted you to see. Is there somebody who can go yes or no?
It hasn't changed from slide 7.
It's not showing you what it used to say and what it did, green and purple.
It says slide 7 only.
Well, forget that. Here we go. I thought, here I was. Now you can see the green and the purple.
Yes.
Okay.
Yes.
So basically, in the original position, it said we want the goals, we want universal for everybody, essential care and so forth. And then it said the league favors a national health insurance plan financed through general taxes in place of individual insurance premiums. Well, for those of us who want to advocate for a single payer, we recognize that's single payer. Okay, it was in there, but unless you know that that's single payer, you don't know that it is. So what New York State put in, they left that statement, and then they're hoping the next statement will be the league supports the single payer concept as I can't read it because they've covered the single payer concept as a value and desirable approach for implementing the league position on equitable access, affordability, and financial feasibility. Here for the state-based plan, it was kind of, I'm a linguist, so it was ambiguous, right? There's that or down there. It says that the league is opposed to the administration of healthcare systems solely by the private sector or the states. Well, can you do it with the states if it's not solely by the states? Anyway, so they just very clearly said, look, until we want a national position, until that happens, states can do it. And then the big thing on cost control is they had just one sentence. The league believes that efficient and economic delivery of care can be enhanced by such cost control methods as, and then they listed 9 of them. Some of them are fine. Some of them are no longer relevant. It's not anything people are talking about anymore. And there are some where the evidence around them has changed. So we probably would not recommend them. But by putting in cost control measures should reflect the most credible evidence-based research available, and favored measures should not exacerbate disparities among patients. And then they left the list as it is. Anything that doesn't meet that is not something that you would want to advocate around or lobby for. But if it does meet that, then it can. Now, it also adds some modern delivery options, such as telemedicine. Who heard about telemedicine in 1993? Safe staffing, that comes up, is particularly put out. It comes out all the time. We're having all these union problems with hospitals and so forth. And taking the middlemen, we have so many middlemen in the decisions about healthcare. So saying specifically, patients, family, and providers decide health. And a big new section on public input, and which is, of course, and democratic governance. So those were the things that we put in, and it wasn't any magic formula, but we used the infrastructure of the league, that every 2 years they do this big program planning, and they have a big survey where people add and say, okay, we want to go along with making democracy work, but we also want to talk about these topics and this topic and this topic. And so we were able to get through to a couple of hundred leagues, of which 100 actually got back. Now, we only heard from about 80, so there's 20 people that just answered anyway. And it became, and this was many, many more than the LWVUS had usually have answering that particular question. So they were very impressed with it, I think, and they recommended it, which was a huge boost. And we were thrilled that at the convention, the vote came out 868 to 8, even though. So before we transition to part 2, are there any other questions on the concurrence, or is that more clarification than you hoped for?
I think we can go to any questions a little bit later.
Okay, so this was animated, so it wasn't such a busy slide. But anyway, so what's the result of having done this? So one result is, when I first came into the league, people didn't talk about single payer as part of the league position. We were working to try and get it in the position when it was in there all along. And now when we would go to other leagues, they would say, oh, we can't talk about that. We're doing Medicaid expansion, or we're doing this, but the league is supporting ACA. They're not supporting single payer. So I believe that the activity about it has reintroduced single payer into the league discourse. And the very important piece about it is that with it saying that single payer is in the position, if someone doesn't believe in single payer, I don't know whether some people don't think it's a good idea. They don't want to they don't have to campaign for it, but they can't oppose it. So as Joey and Rob are going to show you, there are tons of issues in healthcare for us today. And so there's lots of things, but for those of us who feel that the ideal solution is a single payer Medicare for all program, it's really a help to have it in the position. Will League LWVUS do anything different by virtue of having had the update? And I think the answer to that is not automatically, but we have a task force, and we're working on strategic ways to find something that doesn't take too much effort on their part to say yes, and that we will be able to lobby our members of Congress on the federal issues. But for now, as I'll tell in just a minute, we're restricted to doing more things at the local level. So if we start with, I'll start there. And I don't know, I hope everybody is familiar with impact on issues. It took me a while to figure out that those first 5 pages where they say taking action together, they have all these principles they really believe, and they really try and enforce. So they distinguish grassroots from federal. So is your issue grassroots or federal? Is grassroots local or state? Or is your issue, or is the person you want to speak to grassroots or federal? Are you wanting to do advocacy, lobbying, or education? Okay, so what you do to whom within the league guideline is going to be different depending on which of those you're doing. And then the big thing is it a priority issue or a non-priority issue? So the league has 2 priority issues. Making democracy work, that has a whole bunch of things like the voting stuff and the redistricting. There's a whole lot around making democracy work. And the other one is ERA, and they're getting ready to work on the electoral. For those, advocate, live, lobby, and educate. They want as many people as possible. But non-priority issues, you have to be more careful. So just a little minute definitions of the distinction: advocating, recommending a course of action without and urging, but without talking about a specific piece of legislation. If you talk about a specific piece like HR 1976, then it goes into lobbying. Whereas educating is informing about a course of action, giving its background, its implications, and so forth, but not urging. And one of the things that we did get actual communication about was that, in fact, since this was for Vermont, since they wanted to talk about national things, and they have only a state league anyway, they wanted to do a program with PNHP, but they knew that they weren't supposed to be advocating for something national. They said, well, listen, you do all the education part and let PNHP do the advocating. Okay. So you can't control what they say. You choose an organization that's nonpartisan and that shares your views and values and so forth. But they very specifically said, you don't have to worry about that. So basically, as we were talking, a priority issue, doesn't matter if you're talking to a state or a local official or a federal one, you're writing op-eds, and you identify yourself as League of Women Voters. They want to have as many people out there working on making democracy work and so forth as possible. And the same thing when you go to federal. But when you come over, we're going to cross over the line here to the non-priority, which is healthcare. Healthcare happens to be a special category of non-priority, along with immigration and environment, called a watchdog issue. But in most of the time, when there's not something crucial happening, crucial and time sensitive happening, it's considered a non-priority thing. We can, ALE is advocate, lobby, and I was going to put it out and I guess I didn't. Advocate, lobby, educate, and we can do it to state officials. In Massachusetts, we have a bill. So when we're supporting our state bill with our state officials, and we have our state league is in favor of it, is not an issue. But I like, for even my education, when I do education for the federal members of Congress, who are pretty available to us in Massachusetts, so we see them. I like to confirm with at least my local board and the state board if I'm within the guardrails of what I know the position better than they do, but whether I'm representing myself, I can be representing myself as the league in what I'm doing.
So Barbara,
And then
do you
I
have,
can't see
Barbara?
Yeah.
Do you have more slides? Because Joey's up next.
I have one or two. Okay.
Should we save those maybe for question and answer?
Okay. I wanted to just talk about the federal request form, but that'll be fine.
Okay,
So I
why
was
don't
just going
we
to
ask?
talk about the federal request form and what an action alert was. And
Okay.
that's it. I was going to leave the rest for Rob and Joey. Thank you.
Thank you. So Joey, you're up.
Okay.
Oh, so
That's
I should stop sharing. Ta-da.
Okay. Well, I do not have slides, so I'll just be talking with you. And yes, I'll try and be conscious of time so we can get through and get to questions, because I think that'll be valuable and helpful for all of us. But I just sort of wanted to start and tell you all like who I am. I know I had the introduction at the beginning, but I joined the League of Women Voters Indianapolis chapter last year, and that was after getting connected to the League of Women Voters by other single payer advocates. And as I had mentioned, I've been involved with SNAP with his Students for a National Health Program, and that's specifically medical students. We have a national leadership team, and then there's also individual chapters at medical schools throughout the country. So that's an exciting thing that, yeah, I've done a lot with. And And then also my connection to this more specifically is that I spoke at the League of Women Voters National Convention last year on this concurrence. I spoke virtually. And so it's really, I'm happy to see that it was adopted and sort of hear what the next steps and follow through are. So it's cool to see that. And hopefully hearing from me will provide a sense of inspiration and bringing up ideas for collaboration for single payer advocacy in the future. And so I sort of wanted to talk a little about medical students and their role in single payer advocacy. I think it's sort of hard in general because, you know, as medical students, we're having to take the time to learn medicine, which is a lot in and of itself. But I really do think it's our responsibility to better understand the healthcare system and from a patient's perspective, and really learning what we're joining and how it impacts patients. And so I think coming into the healthcare system, we have a fresh set of eyes and we can sort of assess how our healthcare system is working and the ways it doesn't work, and the ways that it fails patients. And a lot of us are very motivated to see change. And I think it's really important for us to keep that motivation and not sort of fall into the trap of just thinking that this is inevitable, this is always how it's been, and it's not going to be any different. And so, because that can end up happening with a lot of physicians who are frustrated with the system, but don't really do much to take the next step to try and change it. And I think that that's like so important for us to get connected with other physician mentors like Dr. Stone who have stayed engaged, and sort of show us like what we can continue to keep doing in medicine. Another point I wanted to say is that I think it's important to recognize the political realities at the federal level, and knowing that our ultimate goal of single payer is going to be a long road, but something, of course, worth fighting for. But in the meantime, it's important for us as medical students and medical professionals to be able to help patients navigate our current healthcare system to the best of our ability. And that was actually an idea for a talk that I gave along with Dr. Stone a few weeks ago, with a lot of just sort of like tips, tricks, other sort of really good resources I think are helpful for navigating the healthcare system. And that the slides from that presentation are going to be included in the information that gets sent out from this presentation to everyone who registered. So yeah, at your own time, please review that, share it. I welcome any feedback you have, but hopefully that's something that can be helpful too. And then so now I'm thinking, I sort of want to talk about what can we do as medical students to advance single payer advocacy and efforts. And I think one of the big things that I've gotten involved with and that's pretty impactful is getting involved with organized medicine, both at the state level with state medical societies and with the American Medical Association at the federal level. And it's a similar process for the League of Women Voters. You know, it's the way to make your voices heard, our voices heard, and making sure that our priorities are represented. And for medical students specifically, I think it's our responsibility to keep pushing for progress and having better positions as we go. And so sort of wanted to share some of my experience about resolution writing. And as you know, it's the way to make things become official policy and have these organizations take stances and or actions on these issues. That included, you know, actually writing, doing the research, writing the resolution, and ultimately testifying at the annual convention. So a lot goes into it, but it's a very rewarding process. And so for the past year, during the last cycle for the Indiana State Medical Association, I authored 4 resolutions, that all of which were passed in some capacity. 2 of them were adopted as written, and one of them, or the other 2, were adopted with amendments. And so one of those, I actually worked with Dr. Stone to write about getting the ISMA, the Indiana State Medical Association, to take a positional stance in support of a single payer system. as you can guess, ultimately that one was one of them that was amended. And so they ended up taking out the language specifically endorsing single payer, but they did keep the core, the other component of it that was supporting universal access to comprehensive, affordable, high quality healthcare. And so, it wasn't everything that we wanted with this, but it was definitely a step in the right direction. And I think that it gives us something to build on for future efforts, because now that that component is part of ISMA policy, I think that it will give us good standing to go for and write new resolutions that are consistent with achieving those goals, which would be single payer. And yeah, it's been interesting dealing with the medical associations, because frankly, it feels surprising to me to just keep supporting the structuring of our healthcare system as is, despite the fact that we know it has a demonstrated and rather lengthy track record of failure, as Dr. Stone is going to go through and make very clear. So yeah, it just always surprises me that continuing to do the same thing is what people would prefer. And it makes me glad that the League of Women Voters has taken the next step to advance this concurrence and strengthen their own position. And then I also wanted to share and have some more context. I am working on several resolutions for this cycle, both for the Indiana State Medical Association and for the American Medical Association. At the AMA level, I joined a group of medical students who I met through SNAP, and we're working on a single payer resolution. And so to provide some more context, at the AMA, at the federal level, it historically and continues to oppose a single payer healthcare system explicitly in its policy. But some hope is that the medical student section for the AMA formally endorses single payer. And I think that that's like a great and exciting point, that it's like the future of medicine is already on board with single payer and wants to see it happen. And we just got to work to get the AMA there too. So the current resolution that we're working on is, the goal is to adjust the current AMA policy to drop language explicitly against single payer. And then this would pave the way for future resolutions to formally endorse it. This same effort was attempted in 2019 for the last time. And it sort of shocked everyone when it narrowly almost passed. So it got 47% approval when it was voted by the House of Delegates, and almost did pass then. So we're hoping that we can build on that momentum and actually get it over the finish line this time. And yeah, I think it's really exciting to be part of the effort and work with medical students across the country who are excited for this. And again, I think it's hopeful to think about the fact that our medical student section already supports single payer, and eventually we will be the ones leading the AMA someday. So there's hope. And then lastly, I just sort of wanted to mention another effort that I'm working on for the ISMA. So during the past year, we had a group of a voter coalition that tried to register as many medical students and medical professionals as possible on campus. And that group of students, we're sort of continuing our efforts the best way that we can. And we're working on a resolution at the ISMA level. And it's aimed to increase voting by medical professionals, and to also have the ISMA endorse efforts to strengthen democracy and actually recognize voting as a social determinant of health, which is something that the AMA already recognizes. And for this, I'm working with my local League of Women Voters chapter to help craft the language. And we'll be working as we continue on our draft resolution to sort of form that and see what would be the most effective to get out of that. So yeah, I know I covered a lot of things there. And I hope it was helpful to share some of my experience. I just want to say I'm very honored to speak at this. I'm really glad to be part of the League of Women Voters and to see how they're strengthening their position for single payer advocacy, because that is extremely important to me. And it's just exciting to see this. So I think I'll turn it over to Dr. Stone next. And thank you all.
Thank you, Joey.
Thank you, Joy. Okay, we'll see if I can have better luck at sharing my screen. And we'll see. So I can see it. Can you?
I can.
Okay,
Yes.
we're good. Okay, all right. So I've been doing talks like this since 2005. And as Barbara said, we're in worse shape now than we were. It's a little depressing now. So here's my opening slide of a bunch of folks who look like me, marching for universal health care, and you can tell they've been doing it for a lot of time because they made this beautiful thing that looks like they hand sewed at this quilt. And then here is a bunch of younger, more diverse people who, like Joey, inspire me. And I think about, there is a real youth movement in the single payer Medicare for all movement, and it's pretty exciting. So I'm going to talk a little bit about the past, but I'm going to mostly focus on how things are even worse. So the first week of medical school, for the past number of years, although unfortunately I got edged out of the curriculum with a curriculum change the past 2 years, but before that, for many years, I would speak to the first year medical students at Indiana University Medical School Bloomington campus, and in their very first week of school. And we talked about the topic was supposed to be medical activism. So it was a discussion about how to be more than just a physician taking care of patients, but how to really try to be an impact on society. And so I would speak to the students, and I would say, I started medical school myself in August of 1973, and it's really tempting to talk about how much has changed since 1973. It's almost 50 years now, and all the breakthroughs and the new technology, et cetera. But instead, I want to talk for a minute about what has not changed, which is how we pay for healthcare. Because in 1973, we had private insurance, and we had Medicare and Medicaid were already in place at that point. We had the VA, we had the Indian Health Service, and we had tens of millions of uninsured. And so the numbers of uninsured certainly went down with the Affordable Care Act, but they still remain embarrassingly, awfully high. And so what we've really got is not so much a medical care system as we have a medical caste, C-A-S-T-E, a medical caste system. And the privileged people have good private insurance, and everybody else is stratified down in different ways, although traditional Medicare remains a really good form of insurance, not so much Medicare Advantage. We'll touch on that a little bit as we go forward. The uninsured are like the untouchables. And in general, everyone of darker skin tones, of different sexual orientations, different languages that they're comfortable with, and so on, have a lot of difficulty accessing equal health care. And so our healthcare system remains a clear example of systemic racism. Institutional racism, and I have to, and so every time I talk about healthcare, I mention that, I bring that up, and even though Governor DeSantis doesn't want us to talk about institutional racism, it's real. And so this is an old slide of all the forms of inequality. Injustice in healthcare is the most shocking and inhuman. Martin Luther King said this in 1966. So now I'm going to go through a potpourri of really bad things that are happening that I haven't necessarily talked so much about when I talk about healthcare in the past. And let's see, depending on where you've got your slide and where you've got it set up for the for your view of people. You may have trouble seeing the right-hand side of this slide, but the steady rise in life and U.S. life expectancy until 2020. So here's the good old days when, despite all of the faults of our healthcare system, life expectancy at birth, 1960, going over, it was rising, and now it's going down. And that's only a bad thing and a sign of just the overall illness and sickness of our healthcare system, and something that's not happening to nearly this degree in any other country in the world. And so it's just another sign of how the U.S. stands alone as having this terribly dysfunctional and cruel healthcare system. So here's another terrible thing. Continuous Medicaid coverage is set to expire. The National Public Health Emergency, the PHE, which when COVID was beginning to cope with COVID, expanded Medicaid to a lot of people and kept a lot of people from being kicked off of Medicaid. And now that is starting, they're calling it the Medicaid unwinding. That's the term you'll see, the Medicaid unwinding, but it's really better characterized as the Medicaid catastrophe, because in Indiana, it's predicted that 500,000 people are going to lose, are at high risk to lose their Medicaid as this happens. And so that's just going to be another disaster for people's health. More bad news, cancer. So this is an article from 2018. It's only gotten worse. A new study delivers the dark financial reality of cancer. 42% of new cancer patients lose their life savings. 62% of cancer patients report being in debt due to their treatment. 55%, $100,000 in debt. 3% file for bankruptcy. More would file for bankruptcy if they lived long enough. It's just, it's horrible. This stuff just is, it's depressing. It causes despair. We'll address that. Now, CVS Health, this slide explains itself. CVS now owns the Aetna Health Insurance Company. It's hiring doctors like crazy. It's expanding in every direction. This cannot be good. This kind of corporate takeover of healthcare cannot be a good thing. Well, if I get myself a little more nimble here, I'll try not to make that mistake again. And then what could be worse than to see a picture of Jeff Bezos under the headline, Amazon joins the Medicare privatization spree, the retail behemoth has acquired One Medical, which is in the Medicare privatization business. So our system is going from bad to worse. What more could we say? Well, Indiana University Health is involved in doing some things that I wish they wouldn't be doing. Like they have an ACO REACH, which we could talk about, but it kind of gets into the weeds, but it's a way to privatize traditional Medicare. And I actually refused to join the ACO REACH aspect of IU Health because IU Health is my employer. And they threatened to fire me for refusing to join. And then they ended up relenting. And so I'm still working, but I'm not part of the ACO REACH. All this stuff, it's so complicated. Now, this is an interesting slide. And notice up here in the top left that this is a slide from the Indiana Senate Republican website. Are Indiana not-for-profit hospitals hoarding money? So the quote from lower down in this piece is that IU Health, the state's largest physicians network, has $9.4 billion in assets or cash reserves that grew by $1.3 billion during 2020. At the same time, these hospitals are seeing such astronomical asset growth, employers are expecting a 5% increase in healthcare premiums nationwide. It begs the question of what are these not-for-profit hospitals doing with all this money? Are they truly benefiting the community? with such high levels of assets, why aren't hospitals cutting fees and charges to benefit Hoosiers? So this is on the one hand, it's a frightening thing because we have so many. We like to think that the not-for-profit hospitals are the good guys in all of this, and instead, what we've got is that they are hoarding huge amounts of money. They're charging very high rates, and so why is this on the Indiana State Senate Republican website? It's because business people are rising up and saying, how can this be? It's becoming harder and harder to work. It's been hard to run a business in Indiana because the not-for-profit hospitals in particular are charging so much, sixth highest in the country. So that's an interesting thing to think about, that maybe there are some ways to work in a bipartisan way. And we're in touch with some people in the Republican legislature and looking at this. But I'm just going to keep hitting you with more bad news. So, so this article was published in the American Medical Association Journal on January 30th. And the author here is a man named Donald Berwick, who a few of you may well know, a very famous guy, former head of the Center for Medicare and Medicaid Services under Obama, and just one of the most beloved physicians in the country. He has, I'm going to make this bigger here to show how he starts out this article. In the mosaic floor of the opulent atrium of a house excavated at Pompeii is a slogan ironic for being buried under 16 feet of volcanic ash. Salva lucrum, it reads, hail profit. That mosaic would be a fitting decoration today in many of healthcare's atria. The grip of financial self-interest in U.S. healthcare is becoming a stranglehold. With dangerous and pervasive consequences, no sector of U.S. healthcare is immune from the immoderate pursuit of profit. Neither drug companies, nor insurers, nor hospitals, nor investors, nor physician practices. So this is the Journal of the American Medical Association. This is right there in a very high-profile place. So it's interesting. Articles like this have got to be getting the attention of some of the people that Joey's going to be working on at the AMA convention next summer. And still another very recent piece. This is New York Times. This is February 5th, very recent. Some of you probably saw this by this physician who's he's a social and political anthropologist and a physician at Northwestern University. Doctors aren't burned out from overwork. We're demoralized by our health system. And this quote, I'll read the whole thing. What's burning our healthcare workers is less the grueling conditions we practice under and more our dwindling faith in the systems for which we work. What has been identified as occupational burnout is a system of a deeper collapse. We are witnessing the slow death of American medical ideology, by which I think he means that dream that we're here to take care of people, that it is noble work and a noble profession. Doctors, nurses, x-ray techs, physical therapists, everybody doing everything. The whole face of this, oops, too quick, let me back up. The whole face of our healthcare system seems to be getting worse and crumbling. And it's been accelerated by COVID, and it's been accelerated by market forces. And so how are we going to get around this? How can we change this? Well, we've got to come back to the basic points. And I'll just finish up with a few things here. So here's this slide that Karen found me years ago, and I've been using ever since. Countries with universal health care. And what we're looking at here are the countries in red, like the United States, which are mostly poor third world countries, plus the United States, who have no universal health care system. Then we've got countries in blue, which have universal systems, some of which are underfunded or imperfect, certainly, and some you can argue about some. China probably should be light blue. Light blue are countries that are in the process of trying to develop. Their stated purpose is they're going to develop a universal system. Mexico's in that category. But the countries in red remain with many of their residents unaffordable to healthcare is unaffordable. And so they stand alone with the United States, whereas the countries in blue have figured out that they're doing this. It's not like we're going to have to make something up that's not been done in the world. Oh, thank you for that warning, my dear timekeeping wife. Couple other things. Okay, this slide's going to take me more than a minute, but this is my next to last slide. Okay, so here is a classic PNHP data slide that is a little bit complicated, but it's from the Institute of Medicine, a report they issued in 2013, and it's comparing mortality, death rates by age, and then ranking the US and 17 other countries, which include Denmark, Finland, France, Switzerland, the United Kingdom, New Zealand, Japan. So the US rank on all these categories up to age 65 is we rank, and all of you I think know this, we rank at the bottom, near the bottom of our peer countries in terms of life expectancy and death rates and mortality. Except at age 65, things change. And so this slide proves to us that we have the capability of having the best healthcare in the world. We could do it. The data is very clear. Medicare is imperfect, but it works awfully well. We've just got to figure out how we're going to take care of everybody. Medicare for all is affordable. The Congressional Budget Office has said so. And so the group that I have been a member of and been on the board of directors of, Physicians for National Health Program, pnhp.org, and then our brother sister organization, Students for a National Health Program, or SNAP. And I'm one of the faculty advisors for SNAP in Indiana. We're doing good work. We're looking for partners. The League of Women Voters has been and will continue to be a great partner. And I'd be happy to answer more questions. And I'm going to end my screen share so that we can be able to see more faces.
Thank you, Rob. We're now open to discussion questions. And as a reminder, to ask a question, please send your name to the private chat to one question moderator, and please be succinct in order to give everyone a chance to ask a question, and then unmute when your name is called. Do we have any questions out there?
Bound to be.
Okay, so I'll ask one that we seeded before. This is for Barbara. What can members and local leagues do to promote this issue and to gain the attention of national leadership?
Gaining the attention of national leadership. Well, I'm not sure we want too much national leadership of the league, you mean, right?
Yes.
Right. So I was thinking when you asked that, of 2010, when you guys did this really great resolution at the convention. And I know one of the people from my town was on your committee, and she came home, and we haven't been able to get her to do a thing since, because they didn't even put it in the report that it had been passed. And then in 2020, we wanted to do a resolution at national, and they said, oh, healthcare is not urgent. I'd like to remind you that was the beginning of the pandemic, before there were vaccines. They said, oh, it's not urgent enough, right? So they weren't really on the same wavelength. And I think we have gotten them there with all the activity around the concurrence. But I think what we need to do is really get as many people. We need to get this groundswell, keep the groundswell going. So I think that we need to be working at the local and state levels to the extent that we can, because we don't have to bother them. But we also need to, what we're trying to do is coordinate with, I didn't get to talk about the federal action request form, which is also in this impact on issues. And it's not complicated. It just, they say, listen, tell us why you want to go talk to this fellow, or woman, your member of Congress. Why do you want to do it? How does it fit with your plans? How does it fit with what we're doing? And we're trying to pick issues so that are both federal and state. So, for example, one of the things that I'm working on is this thing called the State-Based Universal Healthcare Act, which Ro Khanna had in the last session, and he's getting ready to put it back in. So we can help him get it back in and get as many sponsors and so forth as possible. But basically, it's trying to help the states. There are about a dozen states that are pretty close. They have both the votes and the bills in Congress and so forth. But they also have the lobbies of they have so much money against. If there's so much money at stake for the people like the CVSs and the Bezoses and so forth, that it's hard to imagine. But we can do things at a lower level. And I think that the more we do that, the more it rises. That's my opinion. And there may probably some other people here, like I saw that Linda Matt Larimer from our group, in fact, the founder of HCR4US is here, and she's been working and making a big impact for a long time in the league.
Thank you. Bill Davis, you have a question? You're up. And then after you, Candy Birch.
I was just wondering if you'd share the slides, but I was also looking at move to amend. I'm wondering if we're going to have to pass move to amend to get money out of politics before we're ever going to get healthcare for all. Any thoughts?
I can respond. I often wonder, do we need to get money out of politics to get single payer? Do we need to get single payer to get money out of politics? There's a kind of, not sure which is the chicken and which is the egg. For me, and this is just my own personal opinion, healthcare has a great a sweet spot for organizing. The reason being that, sometimes we used to, particularly in the old days, we would criticize environmental activists who were NIMBY, not in my backyard, but we know that lots of people actually became activated and excited and worked hard because of some environmental disaster that happened in their backyard. So with healthcare, everybody has a healthcare horror story for themselves, for their family members, for people they know, their neighbors, people at church, people in the union. Everybody's got a healthcare horror story. So there's a lot of ways in which healthcare can be a really good place to organize, but it's really tough. And when we see how the healthcare industry is becoming increasingly consolidated, as I showed with CVS and Aetna. And so they've got so much lobbying money. So I don't know how we're going to get there. But I think in the meantime, I'm going to keep working for it, because for me, the best antidote to anguish and despair is activism. It's getting out there and talking about it and doing stuff and meeting people. Meeting Joey has been great. Meeting Bill Davis years ago when he came over to Indiana from Ohio. There's a lot of great stuff. Working with Kathy Roundtree. So I can see that Barbara wants to pitch in here too. So anyway, I don't know if that was a totally rambling answer to your question, but that's what I got to say.
No, thank you.
Candy's up next.
Can I answer too? A little
Oh,
bit?
sure. I'm sorry.
Well, I just want to thank Mr. Davis for bringing up Move to Amend, which I think is to get corporations out of our government, right? And
It is to end money as speech and
right.
corporations as persons.
Well, and the whole thing, that movie, there was a 2003 movie, which I'm sure you know about, but if others don't know about it, I wanted to mention, there was a 2003 movie, which is free to view. And then there's a new one. The 2003 one, I think, was even that said, yes, if corporations want to be people, they're psychopaths. And they went through the whole diagnosis of all these different activities that corporations have done over the years that qualify them for a diagnosis of sociopathy. Okay. And there's just it's a terrible person. I mean, it's a person, but you can't, but what is it? There's no mind to change and there's no body to jail. So there's no way to control this person, right? And anyway, so if you haven't seen just the corporation, the movie, it will spin you around, I think. But it's realistic. What can I say?
Thank you.
Candy?
I believe that both Dr. Stone and Barbara have answered that question, but I really do love the idea of if more local leagues were having programs like this and beginning to do more things and literally sending in those federal action request forms, and the United States League is inundated with those requests, then perhaps then they begin to see that there is an urgency to this. And as Dr. Stone said, there isn't a place in the United States where there isn't a horror story. And so having those happening at the local and state level, harder to do than easier to say than to do. But I believe that you're on the right track there. Thank you.
Okay, Michelle Famula. Did I say that? Oh, all right.
Yeah, that's totally close enough. Hi, our league is in Davis, California, and what we've tried to do is to reach out through the healthcare interest group to other leagues in California to recommend that they prioritize healthcare in their recommendation to the state league for their new priorities going forward. Right now, the state league's priorities are criminal justice reform, housing and homelessness, and climate action. Now, no one's going to argue that those are three really important things in California. So there's not a lot of motivation to change away from those. And some of the feedback we've gotten has been exactly that. We care a lot about healthcare, but we don't see our league sending forward three different ones, even though our league is going to do that. Some people have suggested maybe we suggest to our state league to couple healthcare legislation where it impacts homelessness or climate or social justice or criminal justice. And so I'm wondering what you think about that. And then I had another question after you respond to that one.
Well, let's let others. We've got one more person with a question, and then you could come back, Michelle, for your
Sure.
second question. Okay.
That would be fine. Thank you.
Should we have Barbara respond to that though?
Well, I just wanted to add that I don't see how the league can ignore the diversity, equity and inclusion element that the healthcare can bring. And we're supposed to use that lens on everything.
Right.
So I think we need to make more use of it.
Pam Rader, you have a question?
Yes, I do. I know various states have tried to do their own health insurance single payer, such as Vermont. And there's some hang up with Medicaid that has caused that not to work. I wonder if there's any model state programs, because it sounds like the league's saying, well, we won't stand in the way of states trying to do their own health care, but there's some reason they can't. I'm just wondering if there's model legislation in states that are advancing single payer and whatnot.
I
You
answer
want to
that?
go, Rob, and then I'll follow you?
Okay. So it turns out that this is a really interesting issue, and one that has some controversy. For instance, at the national leadership level of PNHP, there are a number of people who really support the idea of state plans, state initiatives, and then there are a lot of people who think it's not the best strategy. But I know that people, for instance, on this call from New York State, are aware of how much organizing has been done in New York State around their state bill, and of course, you in California also know how much work has been done around a state bill in California. There are plenty of. I think there are. Templates and actually we even submitted a state bill in Indiana in 2007, I think. It didn't get a hearing in the legislature, but we put together a bill. So and I think the other bit of background is that a lot of people know that in Canada, it was Saskatchewan that passed the first single payer in a Canadian province, and then it spread to the rest of the country. So it's a really interesting question, and the answer is not easy, but I think that in California they've come fairly close a couple of times, and in New York State they've come fairly close. And I was involved with the Vermont effort as well, because I used to live in Vermont, and I know a number of the people who were very active in Vermont. Ultimately, there it came down to some issues about fear of raising taxes. And the problem, not so much of Medicaid, although it would have required a federal waiver in the Medicaid program, which might or might not have been easy to do. But also there is, what's the name of that law? ERISA, which is the law that protects companies who do national business to allow them to have their own national health insurance, national private health insurance that isn't regulated by states, and also does other things about pension plans and stuff like that. But it's the healthcare part that Vermont was not able to get. You'd have to get an ERISA waiver. The only state that isn't limited by ERISA is Hawaii, and there's been a lot of work there, but because of a kind of a historical blip, Hawaii is not held back, and Hawaii in some ways would be the ideal state to do the first. And I know people there who are working on that. So I've said enough. It's a really interesting idea, and I'm not sure if that's going to be the way we get there or not. Barbara?
Well, I just wanted to say that two things. That bill of Ro Khanna's is dealing specifically with trying to deal with ERISA.
Right.
And there are more than just California and New York and Massachusetts and Maine and Pennsylvania and Ohio, and the ones that are closest, and Minnesota. The ones that are closest now are Washington State and Oregon. And so it's not a gone idea. The problem with the Vermont issue is it's just become this urban legend. We can't, since it failed in Vermont, actually, Vermont, well, first of all, it was never unleashed in Vermont, but Vermont is probably one of the worst states to do it, because one of the arguments against doing it is that you have to have enough people to be able to negotiate prices and so forth. And they have so few. So we're actually in New England, we're trying to work on a regional plan of cooperation with the small states here, but as well as Maine. We're trying to figure out whether we should try and pull New York in, or whether they'll just submerge us because they're so much bigger than all the other states. But Vermont is not a good example. They don't have enough money, they don't have enough people, and they have too much borders for the thing that they have. So I think the Vermont question we should put aside and ask more about the more current ones. And if you have an opportunity to work on the state-based, we do have an organization, an allied organization called One Payer States. It's also nonpartisan, and it wants national, exactly the way our concurrence worded it. We prefer a national plan, but we think the path to it may be through the states, because you can do local organizing.
Michelle, do you want to ask your second question?
Sure. My second question has to do with mental health care. And so I'll ask it kind of in two parts. Do you think it would be helpful to couple the goal of single payer for medical with the need to improve access to mental health care? I note that in California, we have a separate position on mental health care, although we just have the US position for medical care. And so apparently mental health is very important. And my second question is, you mentioned PNHP, and I'm wondering if there's been talk about integration with mental health and medical from the perspective of PNHP advocating for universal access as well. Thank you.
In terms of PNHP, yes, it's a long-standing policy is that there should be full parity, that mental health is really important, and that the current system continues to really perform very poorly, particularly for the chronically mentally ill, but in all other ways as well. Joy, you want to take a shot at that?
Yeah, I think that you had touched on that for PNHP specifically. And I think the thing that's important when we talk about like what kind of healthcare system, I feel like it can get tricky when we say Medicare for all, because as Dr. Stone acknowledged, there are issues with Medicare as it's currently structured. And so the thing that we like to emphasize is that what we are actually advocating for is an expanded and improved version of Medicare. So expanded to all residents in the United States, which includes citizens and non-citizens, and then improved being that it would have comprehensive coverage for all services, that including mental health care, that a lot of times can slip through the cracks under the current system. But yeah, I just think it's a good point to say like what we're actually advocating for, and not just the issues that are currently there, because we do acknowledge those.
Yeah. So there is supposed to be parity, but it's harder to do Medicare because it's harder to do mental health because it's more, you can't farm it out and so forth. But when I did a little bit of research on Medicaid fairly recently, one of the biggest gains when the states that got Medicaid was that they got better addiction services, and they improved they improved the capacity of their people to work and be productive citizens when they took the Medicaid help to get addiction services as well as the mental health. But of course, we can't solve the whole mental health thing. I mean, what we do, we put them in the prisons. I don't know. I mean, never mind. I see someone else with a question up, with a hand up, so let's do that. But that's such an important thing.
And Karen, at some point, we're honored by my dear friend Don McCann being on the call, and Sandy. At some point, I'd love to, if you called on Don, he might want to comment on mental health, might want to comment on single payer, national versus by state. But
I love that idea. We do have one question that
He's got his hand up. You can't see it because it's white on white.
Oh, yeah, Don does have his hand up.
Oh, he does? Okay, someone would like to ask Joey a question. Is that you, Don?
Well, it's not a question, a statement. So you go ahead and do your questions first.
Well, it just says LWV here, so I'm not sure who asked it. Someone said, I would like to ask Joey a question. Oh, that's you, Kathy.
It's me.
There we go.
Joey, I just wondered when you were going before the Indiana State Medical Association, what were the points that you made that people responded to, and what were some of the points at which you found resistance in talking to the medical community?
Yeah, it's a good question. And yeah, Dr. Stone was with me when our resolution got brought up for consideration. And it was the most heavily debated resolution that we had during that convention last year. It went on for a long time with a lot of different things. And yeah, I feel like it's tricky. So a lot of the opposition, I feel like sort of just came from like red herrings or like things that people would bring in that weren't actually related to the text of the resolution that we wrote. So people would talk about, issues that they thought the ACA should have done this and it should have been fixed there, or talking about like a one-off experience that they had with the VA healthcare system and therefore would distrust a government sort of program in response to this. So I feel like it was good to like sort of see that and try for us to acknowledge and like stay on message for what we're going for. But yeah, I mean, I think that the support that we got, it's sort of hard to say because it was for a lot of different reasons. And I think it's the same thing that we were talking about, that healthcare is a good like thing to rally around because everyone has their own issues with it. And it's the same from physicians' perspectives. For whatever different reason, from issues they've seen with patients, prior authorizations, different things like that, and being ready for change. So yeah, I don't know. It's sort of all over the place both ways, to be honest.
Don?
Yes, first I want to say that I'm
Oops, you're breaking up.
to listen to Joey single payer here in the United States, and it reminds me of Rob and Kara and some of us in the earlier days, and we're kind of exhausted now. But if we got Joey's in our future, that's going to help. And what I wanted to say is, as you know, Bernie Sanders is head of the Help Committee in the Senate, and he has said that he's not going to bring Medicare for all up. He said that the changes will not come from the top. They have to come from the bottom up. What does that mean? We're talking about policy and politics. Well, policy, we've got it right. The League of Women Voters has it right. The single payer model. But the people have not communicated loud enough to the politicians to make them tell Bernie Sanders to bring the legislation before Congress this year. And so, our task right now is to intensify our efforts on getting the people to understand the vast superiority of the single payer model and understanding how terrible the system is that we have right now. And once the people realize that and start demanding the single payer, then the politics will fall in place, and we'll finally get Congress that will listen and bring us a single payer system. That's just my little, I'm way over the hill. I stroked out this year and fortunately recovered enough to be here now. And but I'm still passionate about the cause. And Joey, I want you to carry on and with your friends and the league. They've done so well all these years, and I want them to renew their efforts on educating the public. And Sandy, my wife, of course, has been very active in the league. And anyway, sorry, I just
It's so wonderful to have you here.
Well,
Thank you. Dick Connolly, do you have your hand up?
Yeah. I had a couple of comments, but one I want to just focus on because I don't hear much about it. We talk about single payer. We kind of have a general idea about what that means, but when you talk to people, they freak out about, oh, higher taxes, higher taxes, higher taxes. Have we addressed questions like questions like, where do you get the tax money from? Do you make it a payroll tax? Do you do it with income tax? How do you stagger that? Do you tax all kinds of income? I think there's just people are just nervous. Oh, it's going to cost so much money. Well, it'll cost a lot of money, but it's not like there's not places to go where there is a lot of money. So do we do much with that?
Well, the first thing is, how much does it cost now?
Oh,
People
I know.
are paying so much.
Yeah, but their solution then is, well, let's just not pay.
Not pay?
Yeah, just forget it. We don't care. They don't deserve health care. I mean, whatever.
Oh, you mean, no. I mean, even people who have health care, they're paying so much and they're getting so much skimmed off the top.
Right.
Oregon, we have a very interesting study in Oregon where he's a Republican is interested in healthcare, and I would love to have you share it. And he asks about universal care, and he frames it in a way without saying single payer, and people agree with it, and they're willing to pay taxes as long as it's not more than their premiums.
Yeah, I'm sure. I mean, I don't think people that support single payer would support. They're not so much concerned about what kind of tax it is, but I think some of the people in the business community freak out about that. They don't want to have they don't want to have income over a certain amount tax for healthcare for everybody else. I pay my taxes, so I don't have to worry about paying more. I mean, am I making any sense? I don't know.
You're making sense. We hear that a lot, but it doesn't. I think when you do the numbers, it doesn't work out.
What about this?
Well, no, that's not the point. My point is not it doesn't work out. I know it doesn't work out. That's why I'm here. but we don't push that enough. I think we don't make that point to people.
And that businesses shouldn't have that expense. What about?
I'm sorry, I missed that.
Businesses shouldn't have the expense of having to provide health care for their workers.
Why not?
That they would be more competitive if they didn't have to do that.
Yeah.
We are at the 8:30 mark. Is there a last question anyone has, or should we just wrap it up here?
How about if we just stay with this question a little bit longer?
And we've got another question.
Okay, I
from
mean, you're the
Gloria.
moderator. I'll let you decide.
Do you want to answer that, Rob?
Well, what I really want to do is take advantage of having Don McCann here.
You want to do what?
This question is to take advantage of having Don McCann here because I know he has answered this question so many times in his long career. But I will also add, though, that the question for the business community is a really fascinating one, and that's why the Republicans in the Indiana state legislature are pushing back against the hospitals, and that's why there's this whole group of people, particularly centered in Pennsylvania, organizing business people, because it's the hardest thing for them to budget every year is what their healthcare costs are going to be. And so in a lot of ways, I really think the business community is the sleeping giant. I really think at some point, business people are going to say, we've had enough. We've tried this thing. We hate being in the health insurance business. We just want to make our widgets or whatever we make. And it's going to be a lot cleaner if we just let the government do it in a way that's fair and equal. So that's kind of my take on it. But Don, do you want to get in a couple licks here before we run out of time?
Well, probably the easiest thing is the calculator that Jim Kahn developed, and people can take that calculator and put their own numbers in and see what the system is going to cost them. And for virtually everyone, it turns out very favorable, except for maybe the very, very wealthy are going to have to pay more taxes. So, and that's favorable if they care about society, about their fellow man. So anyway.
We'll include that in the stuff we sent.
Jim Hahn was a professor at UCSF, and he's my editor for Health Justice Monitor that we put out.
So,
yeah.
Gloria, do you want to bring us home?
Quick question. Can you hear me?
Yes.
People said I'm not speaking loud enough. Can you hear me?
Yes.
Yeah.
All right. A quick question that I think maybe requires more education. So I'm probably ignorant asking it, is about Medicare Advantage program.
Oh.
What I think of, maybe erroneously or accurately, as a hybrid, whereby Medicare is also working with the private healthcare. Is that correct, more or less?
That's a really great question that we probably don't have time to go into too much detail on.
Well,
but let me just take a quick shot at that. It's sometimes called the Buttigieg plan as well. Indiana's Pete Buttigieg was pushing a way to get universal health care by expanding Medicare Advantage. My own feeling on it, and it's a complicated issue, is that Medicare Advantage is actually one of the great thefts going on, the great scandals going on, because the Medicare Advantage plans actually suck more money out of the U.S. economy than the annual budget of the FBI. It's billions and tens of billions of dollars. So actually, but they look so good when you listen to the ads that come on every December and stuff. So I actually counsel people, you make your own decisions about whether to do traditional Medicare or Medicare Advantage, but the policy behind Medicare Advantage is actually really bad. It's really good for the insurance companies, but it's bad for the economy and bad for the health of people. It's a big topic, and we're out of time, but
and there's also a move to take the word Medicare out of Advantage. So I want to thank, I'm sorry that we have to end. It's a little after 8:30. This was fabulous. I want to thank our presenters, Barbara Pearson, Dr. Rob Stone, and Joey Ballard. Joey had to leave because he had a SNAP meeting that he needed to attend, but so he's going to get in touch later. And thank you to all of you for joining us. We had 42 people participating in this forum. So we want to thank Community Access Television Services, Monroe County, Indiana, and our team, LWV Brown County, LWV Bloomington, Monroe County. And you can follow the work of the Nationwide Healthcare Discussion Group, HCR4US, through their newsletter with a wealth of information and a toolkit on the webpage. And please join us in continuing this conversation and advocacy for the healthcare position of the League of Women Voters. And just a shameless promotion here for Medicare for All Indiana. We're going to present a new film, a documentary film called American Hospitals, Healing a Broken System, on April 24th at St. Mark's United Methodist Church at 7 p.m. And there'll be more information to follow. So please make sure that we have all of your information so that we can continue this conversation. Good night, everyone, and thank you so much for attending.
Good night,
Thank you for
everybody.
hosting it.
Night.
Thank you.
Thank you, everybody.